All right, so the next one we're going to talk about is chest trauma, and kind of review some of the anatomy associated with that and some of the procedures and treatments. For the most part, all of our treatments on this one should be about the same. We're going to kind of work through that. Again, let's kind of talk about assessment techniques and so on. Obviously, you start to take a look at this. This is kind of a hot topic when it comes to like gunshot wounds and trauma care and things along those lines. We'll talk about some of the different conditions that are associated with this. Of course, my clicker just stopped working. It was working a second ago. All right, so what we're talking about on the chest trauma side is a couple of things. Obviously, in the blunt force trauma side, we're talking about an injury that does not break the skin. So fractured ribs, bruised ribs, if you ever had either one of them, they pretty much feel the same, right? They cause the same impairment when it comes to breathing and discomfort. On the compression side, obviously, we're going to talk about some like traumatic asphyxiation, crush style injuries that we'll talk about. Penetrating objects, we're going to talk about the different injuries associated with that on the bullet, knives, glass, steel rods, things along those lines, and kind of talk about injury patterns and things that are consistent with that. The first injury we're going to talk about on the closed side is kind of reminding ourselves about what a flail chest segment is, or a flail chest, and maybe a newer treatment that you may not have heard, depending on how up to date you are on information. But flail chest, someone define it for me. How many ribs? 2 or more. 2 or more. And how many places have to be broken?
2 or more.
2 or more. So 2 or more ribs broken in 2 or more places. That creates this segment, right? And that segment free floats, right? Now the confusing piece is we mix the terms up. The injury itself is called a flail chest, right? Or a flail segment. The movement it makes, we call it paradoxical motion, right? And I was trying to see if it was, I don't, but paradoxical motion, and I'll show you a video here in just a second, is the movement it makes. And what happens is when the chest falls, that segment appears to rise. And as the chest rises, that segment appears to fall. So it's an opposite motion of what the rest of your chest cavity is attempting to make. Now, that's going to impair some breathing. On the flail segment side, work of breathing is increased because now we've lost some integrity to that chest wall. The work of breathing is increased. What happens to your tidal volume? It goes down because no one wants to take a deep breath with these, right? It hurts. So the tidal volume goes down substantially. And to remind yourself, we'll talk about it again later, an average tidal volume for an adult is about 500 mLs, right? Well, the downfall is 150 of that never reaches your alveoli anyways because you have an anatomical dead space that's created, right? So we're only talking about 350 mLs reaching your alveoli that's participating in oxygen exchange. Well, if you take your tidal volume for a broken rib, and if you think about that, how many mLs do you think you want to breathe to not expand your chest cavity? We think 300 mLs, 200 mLs? Well, if 150 that's not reaching the alveoli, that means your tidal volume is now decreased to 100 or 50. And if you only took a 50 ml breath, I'll bet you don't last very long, right? So really, really be aware that these patients are going to be respiratory distress that rapidly goes to failure. They could easily go to arrest. Make sense? Now, here's the treatment difference. Before, and I don't know when this changed, but a couple of years ago, we were teaching big, bulky dressings on that segment. You put that bulky dressing in there, you tape it down, you stabilize that segment. Now the recommended treatment is a positive pressure ventilation, so something like CPAP. And what that does is it overinflates their lungs, which they don't really appreciate, but it stabilizes that chest segment to keep that from flipping back and forth. And CPAP, or positive pressure ventilation, the nice thing is now they're continually getting high flow oxygenation that's helping them participate in that gas exchange. Does that make sense to everybody? So that's kind of the treatment difference. Now, if you don't have CPAP or you're worried about that positive pressure ventilation, then that's okay. Go ahead and stabilize that flow segment and go ahead and put them on high flow oxygen and get them transported. Right? And that's going to be the biggest thing anyways, is that transport and definitive care. So we're going to watch this video real quick, and it gets you a chance to see what paradoxical motion looks like. Hold on one second. All right, so here's that paradoxical motion, right? So see that segment that's going the opposite way of respiration? That's what we're talking about. So as they inhale, it's sucking in, and as they exhale, it's actually flexing out. Okay? Oops. So again, what we're talking about is that flailed chest is the actual injury. That paradoxical motion is the movement it's actually making. On the patient assessment side, think about the MOI, right? Because everyone kind of forgets that you took a hard enough blow to the chest cavity to break 2 or more ribs in 2 or more places. Depending on what side of the chest you're talking about, like in that guy, I think it was the left side of his chest. Well, what are those ribs protecting? His heart and his lungs. And let's not forget about hearts and the ability to be bruised and cause things like cardiac tamponade. And we really can't treat that in the field. So being aggressive, being like, listen, you took a high enough MOI, crack your sternum, break some ribs, let's get you transported. Now this could be an assault, this could be an impact to a steering wheel, this could be a fall, it could be something along those lines. Just think about the mechanism of injury associated with that. Obviously difficulty breathing and hypoxia, so make sure that you address those properly. Those are, again, on your high priority list. Pain, you can argue, do they need ALS for pain management? In this case, the ALS is not there on the high priority list of pain management, more for the breathing issues and maybe the decompression side. Pain, I know it hurts, we understand that, but not real high on our criticality list. Likely signs of shock or hypoxia. Don't forget respiratory rate, tidal volume, saturations, and so on. And then that chest wall contraction is going to cause some pretty substantial issues when it comes to breathing. On the actual care side, for you as an EMT, oxygen and positive pressure ventilation if you have that as an option. Make sense? Follow your local protocols when it comes to using that CPAP if you have them. Monitor your patient as carefully as you possibly can. Pay really, really close attention to their rate and depth, because what you don't want is them going into failure and then you have to be dealing with a patient who's no longer breathing. Open chest injuries. To me, this is a little bit easier to handle, right? The closed chest trauma a little bit harder, but open chest injury is pretty straightforward, okay? Would you consider this to be a life-threatening problem? What do you think? Yes, right? Which means in your assessment, you can justify treating this anywhere. You could walk in the door and look at someone with a hole in their chest and say, that's your #1 priority, right? Now, you'd be like, hey, yo, grab C-spine, but that open hole in the chest, it's great if they have an airway, but is it going to do you a whole lot of good, right? It's just going to add to that pressure change. So let's occlude the dressing or occlude the wound and then worry about breathing for your patient, okay? So be really aggressive. Don't take for granted the fact that if they're wearing a shirt, they could still have an open injury. Make sense? Bullet holes don't blow people's clothing off. Okay, it could be very easily missed. Or on the criminal side, it would not be uncommon to get shot and put something over that, like a coat or a sweatshirt or whatever, and attempt to hide that. So make sure, we'll talk about it more in patient assessment, that you cut those clothes and get a good assessment of what's going on. Okay? So obviously the problem with this is you open your chest to an environment that's at a higher pressure than what you're currently experiencing, right? Every time you take a big, nice, deep breath, you're going to suck air into that chest cavity, right? And what's really cool is everyone thought, excuse me, that our lungs are like balloons, right? When your lung pops, quote unquote, it doesn't explode like a balloon and go into nothing, right? You can take a human lung and shoot it with a 45 caliber handgun and bag the trachea, and your lung will still inflate just like it's supposed to, right? What happens, though, is every time you inflate it, it adds to the pressure inside your chest cavity. And that's the bigger issue. We can't do anything about the lung. What we can do is treat the pressure that's now getting inside of that chest cavity. Okay? So we called them sucking chest wounds because of the whooshing of air that it makes, usually bubbling or something along those lines. It may or may not make a sucking noise. A really good rule of thumb is if there's a hole in the chest, you're going to cover it. Period. I don't care if it's making a sucking noise or not. They have difficulty breathing or not. If it's an open chest wound, they get an occlusive dressing. Okay? And if you've never heard one of these or see one of these, let's show you a quick video of what that looks like. It's a pretty large hole. Center mass. Okay? So on the patient care side, right, and there's a critical step that you probably learned in your EMT class that I don't want you to forget. That critical step is, what is the easiest way to seal that wound instantly? Your gloved hand, right? And what's funny is, I don't care if you want to think about this like it's direct pressure because it's bleeding or because I don't care. Put direct pressure on it, right? Now, the downfall is that the lung itself is damaged. Every single time they inhale, you're going to add to that pressure, right? That's okay. Occlude it with your hand. Get an occlusive dressing. Now, if you have an aftermarket occlusive dressing like an Asherman or a SAM or whatever, it's got a one-way valve, that's awesome. If not, Ziploc bags, packages of your gauze, whatever, something non-porous. You put it on the chest, you tape it on 3 sides, right? Now, the purpose of that 3-sided dressing is it allows air out, but not allow air in. Now, here's the problem. There's not a lot of research that says that taping on 3 sides actually allows air out. So what you got to do is you've got to pay attention to your patient. As your patient starts to worsen and develop that tension pneumothorax, you have to burp that gauze. And what you do is when they exhale, you're just going to lift that gauze and it'll actually allow air to escape out of that. When they go to inhale, make sure you cover that because you're just going to contribute to more of that air. Does that make sense? Now, the aftermarket seals are great. The only downfall is all of them involve glue, right? And if you've ever had to put glue or sticky or tape or anything on a chest full of blood, it becomes problematic. So make sure you wipe that clean. The nice thing is some of these come, this is an Asherman with a valve. This one's really nice because this actually has gauze on one side, and you use that to wipe it. When you peel off the backing, the gauze stays in the backing, and then you stick that sucker right to the chest, and now you're treating that bullet hole. These are all just different ideas. This one doesn't have a seal or doesn't have a valve, so you're going to have to burp that one every time you get attention. But for the most part, all these have the same exact idea when it comes to treatment. Okay? If you're going to use a piece of plastic or something like that, here's what you're looking for. It's a bad representation, in my opinion, because the tape needs to be wider, right? Don't grab the half-inch piece of medical tape. Go for the 3-inch tape, the 4-inch tape, something to give you a really good anchor when you're putting that on the skin. I was going to go back just to make sure I wasn't going to miss anything. So we'll talk about the patient assessment side of that here in just a second. Again, does the open chest injury require an occlusive dressing? The dead answer giveaway is if it's open, it requires that dressing. Way to go. Does the patient's injury necessitate immediate transport to a trauma center? Obviously, it's going to be important. Ryan, you know where the mop is. This first door on your left. There's a little cleaning closet. Get them to a trauma center. If you've got a nearby trauma center, awesome. If you're making a run to Sacred Heart because it's your nearest trauma center, that's fine. Just get them to a hospital that's capable of taking care of these patients. We're going to kind of talk about specifically about pneumothoraxes and hemothoraxes and so on along those lines and kind of go down into those. Pneumothorax is, the definition is just air entering a chest cavity. And what everyone kind of forgets is it's possibly causing a lung collapse. Initially, you might have good lung sounds. So don't use absent lung sounds as your red flag for a pneumothorax. Does that make sense? Because initially, your lung will expand and deflate just like it's supposed to. On the tension pneumothorax, this is where air gets in that chest cavity and creates so much pressure it can't escape, and now it starts to collapse that lung tissue. And we'll talk about some of the side effects of that here in just a second. This is looking at just a simple pneumothorax. You get inside that pleural cavity and causing some issues. I want to get to the pneumothorax piece here in just a second, or the tension, sorry. Once you start developing all this pressure, then this lung will completely deflate. This is where you get absent lung sounds, right? A late sign of this is it starts pushing that mediastinal shift all the way over, and now you get tracheal deviation, okay? Here's what I'm telling you. Do not wait for this sign and symptom, right? Address this and treat it long before that, right? Don't hang out and be like, well, it's not a tension until your trachea starts going 45 degrees the wrong direction, okay? Be aggressive. You got some shortness of breath, you got some issues. This is an ALS procedure. Let them get there, let them do that needle decompression and get them treated as quick as possible. Does that make sense? The hemothorax side, not a whole lot of treatment changes because we're just talking about the introduction of blood inside the chest cavity. We really don't do a whole lot. You're still going to chest seal it. You're still going to call for ALS and work through that process. Here's your look at tension pneumothorax. And this is kind of on the clinical side, but that's okay. Shock-like symptoms, difficulty breathing, chest pain. If you're shot in the chest, I would assume you're going to get some chest pain associated with that. Central cyanosis, maybe some right-sided heart failure with some congested neck veins possibly. That late side, again, that tracheal shift to opposite side, and then a unilateral bulge of the chest with movement, right? So kind of be thinking about that. Mostly you're going to be treating it up here on this side, right? We're not going to do any sort of tympatic resonances, anything like that. I want you to listen to lung sounds. I want you to get good at that side, which we'll talk a little bit later. But be picking up on a tension pneumothorax as quick as possible. Okay? So on the ALS side, I share this video just because it's a really cool video of a needle decompression inside somebody's chest. So I want you to kind of get a chance to see. And you can see how quickly this will inflate. So this is done with the scope, which is super cool. So this is just looking at the chest cavity. Here's your needle that comes in. You're going to see why they pull the needle out here in a second and just leave the catheter. But look, even right away, this lung is starting to try to reinflate, right? So they pull the needle out so you don't have a sphere sitting inside there waiting to meet your lung here in a second. But look at that. Now they throw some CPAP in there, and look at that. And immediately, we're talking a few breaths, that is already improving the patient's breathing rate. Right? Another good look at why you don't leave the needle in there. Because you be like stab, 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 stab. The music makes it just that much better. Does that make sense? So that's the purpose of getting that ALS on board as soon as you possibly can. YouTube's a great tool, isn't it? So let's look at the traumatic asphyxiation side. When do you think is the most common time on the civilian EMS side that we're dealing with this? What do you think? What's the most common MOI with this? Car accident. Maybe car accident. We're talking much more forceful. Maybe an auto versus pedestrian. What do you think? What other MOIs would be a heavy object compressing the chest cavity and causing damage?
Piano phone.
Maybe, yeah, like on the Acme, like Roadrunner side, absolutely. Let me get a video of that. Bugs Bunny. No, Roadrunner and Wile E. Coyote. Yeah. What about like working on a car? Right? Jack stand kicks out, that car comes down and smashes. In the industrial setting, obviously much more options for MOI on that one. The dead giveaway is almost always this really distinct injury pattern. Notice how they're pale from one line all the way down. They're very red, purple, broken blood vessels on the way up. Make sense? Car comes down, smashes the chest, pushes all that blood into the head, can cause broken blood vessels in the eyes, broken blood vessels in the face. their face presents really, really dark in color to where the rest of the body is lacking blood. Therefore, we're going to present like a pale color. Make sense? This is the most common presentation. So here's the downfall. Compresses the chest. If they're in cardiac arrest, you're going to try to do chest compressions. If you don't have any musculoskeletal structure there, you're going to be really, really working hard to get some perfusion, things along those lines. It's a traumatic death, so the chance of survival is low anyways. We're still going to start CPR, work through your guidelines, work through your protocols. We just understand that it may not have a favorable outcome. Cardiac tamponade. This is the one that we got to kind of take a look at because there's no treatment in the field, especially on the EMT side. Depending on the protocols, on the ALS side, maybe. But for the most part, the treatment is get them to a hospital and let them do an invasive procedure. So what we're talking about is you have this pericardial sac that surrounds your heart. And it's got, I don't know what the actual number is, 10, 15, 20 mLs of blood already in it. But when you take a blunt force impact to the chest cavity, it bruises and causes excess blood inside this tissue. What it's going to do is it's going to start to compress your heart. And inside that sac, it just starts to squeeze and squeeze and squeeze and squeeze until you no longer can perfuse like you're supposed to. So what we have is what's called the Beck's triad. And Beck's triad is a three-sided signs and symptoms that would indicate this as an injury because there's no other way to predict it in the field, right? So what you have, Beck's triad is actually distended neck vein, so that's your JVD, muffled heart tones, which I know you're not listening to as an EMT, but on the paramedic side, and then hypotension. Next to hypotension is actually a narrow blood pressure, right? So we'll talk about pulse pressures. It's narrow, right? It's less than 20 difference in pulse pressures. Okay? So you got distended neck veins, hypotension, and muffled heart tones. So what you have with this, the other really unique thing about this is when they take a big deep breath, their JVD will actually go away or will decrease because they're increasing the space in their chest, therefore there's not as much pressure on their heart. When they exhale, you'll get that JVD back. So that JVD kind of comes and goes and comes and goes. Okay? On the in-hospital side, you actually have a drop in blood pressure when you inhale and exhale, but we don't have a continuous blood pressure monitoring ability in EMS, so we can't use that as a tool. Now, here's what I always tell EMTs. I always have EMTs who say, wait a second, I don't know how to listen to heart tones. You're right, I'm okay with that. If you have these two, distended neck veins and hypotension, as signs, and you have an MOI consistent with this, then just call it a possible cardiac tamponade. I don't care if you can't listen to heart tones or whatever the case might be. You got distended neck veins, hypotension, and the MOI consistent with this, get them transported. This is a rapid transport. This is a helicopter. This is ALS. This is whatever you have to get them to the hospital as quick as you possibly can. Make sense to everybody? Yep. I don't in this PowerPoint, but I'll find one. Google images. Yeah. We can step on your chest and see what it looks like. Yeah, that'll work. Aortic injury and dissection, right? What's the downfall with our aortic dissections on the trauma side? What happens when that thing rips in half? They did. Right? How long does it take you to bleed to death? Seconds. Right? What MOI with car wrecks is really consistent with aortic arch tears? Anybody know? It's one distinct MOI. It's lateral, right? It's your T-bone collision because your body moves side to side. And here in a second, or in a couple slides, we're going to talk about if you think that if you're driving in your driver's side car and you get whacked from the passenger side, how much is protecting you from the bumper of the other car if you're hit on the passenger side? Feet, right? What happens if you take it on the driver's side? It's right there. In fact, some of us do things like hang your arm out the window or whatever. You're leaned against that driver's side door, and you're taking all that impact right directly to your chest cavity. And your body moves sideways at 60 miles an hour, while your heart and your air stay still. And it just rips it right in half. And you bleed to death before your car probably stops spinning. Okay? If they do survive, signs and symptoms of shock, pain in the chest, pain in the abdomen, the medical side, that tearing, shearing, pain in their chest or their back, things along those lines. Be thinking about checking. How many of you check pulses in both feet? Yeah, me neither, right? But like, think about that. Like, okay, well, if you're thinking of an aortic injury, make sure they have an equal rate and strength on both feet. Most of us are like, you got one, we're good on the trauma side. But we're thinking about, are they actually equal? Because that could be an indication of an aortic injury. Okay? Who's ever heard of commotio cordis? Anybody? Ryan's heard of it. Right? So this is a really unique, it's not very common. What's interesting, I'm going to show you a video here in a second. There's been a couple of times we've seen this in professional athletes. And what happens is, you have this window, and I literally mean a 20 millisecond window where your heart is the most vulnerable to an impact. So here's what happens. These are typical mechanisms of injury. Hockey puck, lacrosse ball, baseball, fist or elbow. It could be a steering wheel. It could be, something like that. But what happens is right when you're trying to repolarize, you get an impact. And now the force could be varying, right? You think about a lacrosse ball, they can huck that at a pretty high rate of speed, right? Hockey puck, depending on the caliber of which we're talking about. But think about a fist or a blow, right? That's not that high of a force, okay? So what happens is your heart gets whacked. You get that blunt force trauma, and you go into VFib, right? It causes I think it's a sodium-potassium issue, and your heart goes into VFib right now, right? So what happens to you as a person? To the floor, right? Now, what's the good news about this? What's the good news about VFib? It's shockable, right? So it's like, wait a second, you show up on scene, and the most common, and the NREMT uses this a couple times, the most common test question is 9-year-old kid playing shortstop, gets whacked in the chest with a baseball and hits the ground. You show up, bystanders are doing CPR. What should your highest priority be? And that's get the AED on as quick as possible. Because we don't know how long you hang out in VFib. Is it 4 minutes? Is it 5 minutes? Is it 8 minutes? After 10 minutes, it's probably not likely. And let's get real, our response time to most emergencies is about 7 minutes, right? So we're losing a lot of time that we can't be wasting, okay? Now the treatment for this is, it's a cardiac arrest, so you're just gonna treat it. Does that make sense? Not a whole lot of different training, or not a whole lot of different treatment when it comes to that, but definitely wanna be aggressive. So this video is to show you, because this is a punch, this video is to show you how quickly and how simple this can be. Believe it or not, the right punch from the kid to the right, and I'll show it to you again. The kid on the right punched that kid in the chest. That's all he did. Right? I'm gonna go back just so you can watch the whole thing again. You're watching for, it's a right-handed punch right there. And that's it. Right? Now what's interesting is you take a look at this, I don't know what year this is, but thank God we changed CPR protocols. Because think about this, no CPR, no CPR, no CPR, still no CPR. We're still not looking at, like, it takes us a while to get this poor kid some chest compressions. Mostly because I'm sure the conversation going on is, what the hell happened? Right? How in the heck is this kid even dead? And there's a couple other videos you can look for on YouTube because it's happened to 2 NHL hockey players in the last 10 years. About 15 years ago, it happened here in Spokane to a kid playing for the Spokane Chiefs. Took an impact against the boards, skated from the boards to the bench, and was in cardiac arrest before. As he sat on the bench, he tipped over backwards and was dead. They resuscitated him, thankfully. All 4 of these, the 2 professional athletes, the kid from the Spokane Chiefs, and this kid, all were successfully resuscitated. Right? Again, that's the nice thing. You're in a shockable rhythm that let's hope that we can get that AED on board and get you flipped over to the perfusion side. Make sense? So breath sounds, right? You're going to use those breath sounds. Now, here's the downfall. Don't forget that you should reassess your breath sounds. Does that make sense? Listen to them initially. Just because they're equal and clear bilaterally right now doesn't mean in 15 minutes that's going to develop into a absent on the right, absent on the left, you're going to start to hear that go diminished, right? So think about that injury pattern, obviously, as it starts to go through. Now, if you have an impaled object, be aware that if you haven't popped that lung by the object, as they start breathing, you will always run the risk of that causing that lung to actually collapse. Okay? Any questions on that one? Pretty easy, pretty straightforward.